Hello, good evening, everybody. This is Thursday, Wednesday, the 20th, and it's a real pleasure for me to open this interesting meeting organized by the Eastern European Committee of the European Society of Shoulder and Elbow Surgery. We tried to organize this meeting with an appealing topic, which is reverse shoulder arthroplasty. And I would like first to say thank you to Ali Erşen, who, as chairman of the Eastern European Committee, is been chairing this meeting and he's been preparing this meeting. And for this purpose, we are have a good group of speakers. So first from Turkey, Kerem Bilsel will participate. Also from Poland, my good friend Kordasiewicz. From France, my good friend Philippe, Collin. And from Italy, the chairman of our education committee, Paolo, Paladini. So thank you very much, the five of you, for being present here and for accepting to participate. And I would like just to hand over to Ali, who is chairing the session. So Ali, please.
Thank you, Emilio, for the nice words. Good evening to everyone. Welcome for our first committee webinar. We choose for this webinar the topic reverse shoulder arthroplasty, for sure for a reason. Although it's already popular in France and in Western Europe, reverse shoulder arthroplasty is getting popular in the Eastern European countries like Turkey, Poland, Greece, etc. So the burden of revisions will also rise if we could not do it properly. So to decrease the burden of revisions, we have this nice webinar with a distinguished faculty mixed from the Western and the Eastern European countries. First of all, Dr. Kerem Bilsel from Turkey, my very close friend, will talk about the biomechanics about reverse shoulder arthroplasty. Then Kordasiewicz will talk about the reverse hand fracture. The third presentation will be from Italy, Paolo Paladini, about the surgical tips and tricks. And the last presentation, our next president, Philippe Collin from France, will talk about the painful reverse shoulder arthroplasty. I think we will do the discussion at the end of the last presentation together. Now it's time to start with the first presentation, Kerem Bilsel from Turkey, about the biomechanics. Thank you.
Good evening, everyone. This is Kerem Bilsel from Istanbul. First of all, I would like to thank Emilio, Calvo, and Ali Erşen for having me to this great SECEC Eastern Committee webinar. My topic is reverse shoulder arthroplasty, biomechanics, and different design features. The introduction of reverse shoulder arthroplasty by Paul Grammont was an important milestone. With his first ball and socket trumpet design, which has evolved to Delta 3 prosthesis 6 years later. Grammont reverse prosthesis is based on the biomechanical principles of a medialized joint center of rotation, distalized humerus to increase deltoid moment, arm, and strength. And also, this is a semi-constrained design which provides static stability with early improved range of motion. And it has promising results, and it gained popularity by time with an updated surgical technique, the innovation in implant design with lower complication rates and with more new indications like fracture and revisions. Reliable functional outcomes and long survival rates can be achieved with up to 145 elevation, especially for cuff tear arthropathy cases. According to Luc Favar's study, the long-term survival rate was 89% after 10 years, and the minimal functional deterioration up to 8 years, and the radiologic scapula notching of stage 3 to 4 after 5 years. But there are still some limitations in Grammont prosthesis. The scapular notching, which cause the polyethylene wear and osteolysis, external rotation weakness, the internal rotation deficit, the instability, and the loss of shoulder contour as a cosmetic problem. Which other solution do we have instead of Grammont prosthesis? We have lateralization design. Does it solve all the limitation of Grammont? We are not sure yet. So before going deeply to the design features, we need to define some points. The center of rotation point placed on the central portion of the native humeral head is the best fit circle to the head with the best fit radius of curvature. And the center of rotation for reverse shoulder arthroplasty is much more relatively medialized and distalized to give the deltoid mechanical advantage. But we don't know the ideal center of rotation for reverse design for optimal soft tissue tensioning. The position of the center of rotation relative to the scapula is significantly changed by two RSA design. They are all medial and inferiorized, but lateralized design, center of rotation, is significantly more laterally placed compared to the Grammont design. And when we compare them on the axial plane, we can notice that medialized type prosthesis has more deltoid recruitment, which gives better anterior elevation. Besides, lateralized reverse shoulder arthroplasty design has much more rotator cuff retentioning to gain better external rotation. According to J.D. Wertel study, the lateralization can be achieved from the glenoid, the humerus, and the implant itself. When we wanted to define lateralization, we need to set 5 different points and lines. The A point represents the humeral diaphysis. B is the humeral cut. C is the pivot point of the insert, the deepest point of the insert. D is the center of rotation, and E is the glenoid bone. The humeral lateral offset is consisting of stem and insert lateral offset, and its upper limit could be for plus 14.7 millimeter. The glenoid lateral offset is defined as a sum of glenosphere and base plate offset, which is more limited comparing to the humeral lateralization. And it can be up to plus 8.3 millimeter. And at the end, the global lateral offset can be identified as a total of both humeral and glenoid offset values. Glenoid lateralization can be made by the base plate itself or by the glenosphere, putting it like Frankel type glenosphere, greater than the hemisphere, or by the scapula neck bio-RSA, the bony increased offset. According to Gerber's study, the placing the glenosphere distally with an inferior offset and putting it in a 15 to 20 degrees of inferior tilt improve survival outcomes, especially the adduction and the abduction, and decrease the incidence of scapular notching. But placing the glenoids distally was more important than adding neck length or increasing inferior tilt alone. The humeral lateralization can be made by the stem with the use of the curved stem, or by changing the humeral cut and the neck shaft angle like 135 degree, the varus position, or changing the humeral insert type like inlay, semi-inlay, or onlay prosthesis. The RSA options was described in J.D. Wertel's study, and we have so many implants in the market which were categorized in three types with 22 different implants with a 28 different configuration. The Grumman style Delta T prosthesis serves as a reference point for all of them. And the three categories are the medialized humerus, the minimally lateralized humerus, and lateralized humerus with more than 10 to 15 millimeter of lateralization. We need to answer how much lateralization and distalization needed doing the reverse shoulder arthroplasty. And hopefully Johannes Barth published a paper in 2018 in JSES, and he described two different shoulder angles. And if the lateralization shoulder angle can be between the 75 to 95, it is correlated with an increased external rotation. If the distalization shoulder angle between 40 to 65 degree, this is correlated with the increased forward elevation according to the Johannes Barth study. But we have still some price to pay, like medialized type prosthesis in the lateralized design. These are the increasing shear stress, the polyethylene wear and glenoid loosening, scapular spine fracture, acromial and coracoid impingement, and because of the lateralization, it is sometimes difficult to refix the subscapularis. The bio-RSA described by Pascal Boileau is a safe and effective technique which has a low revision rate and high patient satisfaction by restoring the RSA angle with angled bony increase lateralization from glenoid. This is an interesting study that we did last year in patients undergoing reverse shoulder arthroplasty for calf tear arthropathy, and they had some satisfactory clinical outcomes obtained by achieving an postoperative RSA angle between 0 to 10 degrees with an asymmetrical inferior reaming technique. And we showed that there were no differences between two designs in terms of clinical outcomes. And George et al. In 2021, with patient-specific lateralization He showed that the younger patient below 70 years of age and who are active and slim did well after the surgery. But if the patient is over 70 years of age, less active with comorbidities, increased body mass index, and shorter life expectancy, there is no need to much lateralization. And this is a study of Younguri from Korea. This is a very new one. He showed that we can have faster recovery in onlay prosthesis. But in the end, there is no difference between the clinical outcomes between two groups. And this is a very recent meta-analysis made by Jackson Group. They include 360 shoulders in 4 level 1 studies, and they showed us better external rotation in onlay prosthesis group, but no difference in overall. So at the end, for the take-home messages, we can say that the trend shift from Graham to lateralized reverse shoulder arthroplasty. And the offset concept is the lateralization, but it's also inferiorization of the center of rotation. It can be achieved from glenoids, the metallic augment or bony augments, up to 8 millimeters, or from the humerus with the stem option, neck shaft angle, or with the onlay type prosthesis up to 15 millimeter. The ideal amount of lateralization is still unknown, and there is always price to pay for each design. The bio-RSA, onlay designs, and preoperative planning and PSI gives promising results. Thank you for your attention.
Thank you, Kerem, for the nice presentation. Now it's Bartek's turn to speak about fracture and reverse arthroplasty. Bartek, please, your presentation.
Good evening. I'm very happy to represent Polish Shoulder and Elbow Society. The topic of my presentation is reverse prosthesis for fracture. Which fracture and how? So my first question will be for whom? And I was much disturbed by the presentation and the publication reported in 2015 in a proper study saying that maybe we should not overestimate our surgical skills and our surgical results. And in fact, maybe that our surgical treatment does not give better results than non-operative treatment. Another study, which was reported in this 2015, was studied by Handel, that was multi-analysis, saying that surgery does not result in a better outcome at 1 and 2 years and is likely to result in a greater need for subsequent surgery. So it means that maybe we should not be so aggressive. Since that moment, my qualification for surgery is slightly different, and I like this study reported by team of Bernard Jost, who prepared such an algorithm which seems to be quite complicated. However, it is based on quality of bone, age of patient, activity, and type of fracture. So I'm not going to get into this picture very, very carefully. However, based on this study, my qualification for reverse shoulder prosthesis is depending on age of patient. First of all, I'm trying to operate patients which are above 65, maybe 64, maybe 63, however older than 60 years old. Then we decide whether the quality of bone is good or wrong. If in patients with good bone quality and where the fixation is very difficult, I have to choose between fixation and reverse shoulder arthroplasty, because my aim is to restore function, not only to relieve some pain. In a relatively active patient, however, with low bone quality, I'm discussing with this patient because I propose a non-operative treatment or maybe operative treatment. However, in this case, I say that maybe the main goal of our reverse shoulder arthroplasty would be pain relief, not perfect function. So type of fracture, head split fracture, fracture dislocation, and rarely three-part fractures are main indication for the surgery. I'm much more afraid of varus fractures than valgus fractures. However, as I said, I discuss always these options with my patients. In high-risk patients or really sedentary patients, I prefer non-operative treatment unless patients are very, very painful, and maybe in this case, reverse shoulder arthroplasty could be option for as a pain relief. So another question is how to perform reverse shoulder arthroplasty. They still remain two technical problems: the humerus height or humerus length restoration, or achieving proper humerus length, and tuberosity's healing. So we know that we have some anatomic landmarks, and there are lots of studies saying that pectoralis major tendon could be one of these landmarks. However, we are aware that some fractures are destroying this landmark, and we know that there are some slight differences regarding the precise assessment of pectoralis major tendon position versus some anatomic landmarks. It varies on size of our patients, and as you see, this is a very nice study evaluating this relationship between particular parts of our proximal humerus, and we know there are some differences. And the tolerance of differences when we put the prosthesis is lower than 1 centimeter. I think we have 2, maybe 3 millimeters. So if we are basing on some data and the results are plus minus 9 millimeters, it doesn't give me proper answer where I should put my prosthesis. It gives me some orientation. So I like this study because it shows some relationship between some anatomic landmarks. We can see that we have this calcar area. We have the moment when the humerus is changing its curvature. We have the greater tuberosity relationship to these places. So I'm not going to discuss all this stuff. However, I'm trying to put attention when I'm planning the surgery to all these anatomic landmarks. The easiest situation is when we have some calcar remnants here. We can measure them and we can decide how far prosthesis should be put into the diaphysis, and how many millimeters should rest to restore the anatomic landmark. However, this situation is not very difficult, not very often, so sometimes we are really disturbed. So let's go into fixation of tuberosities. My way of fixation is taught by Dr. Paolo, who showed this technique many years ago, and I think it's quite repetitive. It's quite useful, and I like the study reported 3 years ago by the French group, And in this study, it was proven that the question was whether we should fix the tuberosities or not. And the answer of authors was very clear, that anatomically healed or even repaired tuberosities can result in better final outcome in our patients regarding constant score, regarding external rotation, and subjective shoulder value, which means the patients were more satisfied if the tuberosity or the greater tuberosity was healed. So this is another study showing long-term results in reverse shoulder arthroplasty for proximal humerus fractures. So authors reported many cases and decided that the factors related with better results were tuberosities healing, lower BMI, lower comorbidities, and better general health status, and some surgical factors like using smaller fracture stems, lateralization of glenoid component, absence of retentive insert, which means that the shoulder was more stable just after the implantation, immobilization, abduction, or neutral rotation, and delay rehabilitation, or passive pendulum exercises, which means that we gave some more chances and more time for tuberosities to heal. So in longer time, after longer than 5 years follow-up, better results were after repair of greater tuberosities healing, and factors related with tuberosity healing were smaller stem and immobilization, neutral rotation, or abduction. To sum up this result, the results achieved stable after 1 year. So we know that after 1 year, the satisfaction remains stable for years. Survival in this fracture prosthesis were 91% in 20 years. The intraoperative complications were 2%, and postoperative complications were 12.5%. The most common complication was instability, then aseptic loosening stem, and some nerve injuries. Only 5% of patients required revision surgery, so I think that in this difficult type of prosthesis is not bad result. And mortality related to surgery after 1 year was 6%. Risk factors were age above 80, ASA 3 or 4, or some cognitive impairments. So regarding technical problems related with tuberosity healing, we know there are some discussions whether we should excise or preserve the supraspinatus tendon, because first it may be not necessary because we put the reverse prosthesis, and maybe it's going to facilitate the surgery if we see more and if we control more the position of prosthesis and tuberosities. So in this study, authors said that there were no clear differences, but only better external rotation in elbow against trunk, which means in the first position was better in patients who had supraspinatus excised. So maybe it could be indication for us to excise it. However, personally, I don't do it. I will show it later on. There is another study reported last year, also by French group, showing that greater tuberosity healing gives better results, and we should not excise greater tuberosity, how it was in some studies proposed in the past. it's also excising tuberosities can be, as you see, the risk factor for dislocation and for loosening of the stem. This is another interesting study which was reported in 2015. That maybe one factor which can promote greater tuberosity healing is putting a piece of bone taken from the humeral head to enhance the healing of greater tuberosity, which was called the B-cut technique. I have never performed this technique. However, I found it sometimes maybe useful when the quality of bone of greater tuberosity is not perfect. Maybe it's going to improve our greater tuberosity fixation. So there was only one study I found reporting that there were no big difference between healed versus non-healed greater tuberosity regarding reverse shoulder arthroplasty in fractures. So I would conclude that greater tuberosity is important, and the literature probably supports this attitude. Second problem I started to discuss at the beginning was the humeral slant, which means the deltoid tension. And there's one nice study showing that in fact that we should probably achieve the humeral elongation about 10 to 25 millimeters, which gives the best results in constant score in these patients. How to achieve it? It's not very clear. However, as I said at the beginning, we should rely on some anatomic landmarks and try to restore it as much as possible. Now I would like to show you this case of four-part fracture in a 60-year-old woman, right-handed, working in office without comorbidities. She fell down just a few days before Christmas, and this is her X-ray. Here we have her CT scan, and CT scan with 3D reconstruction. So our first goal during surgery was to restore proper length of the implant. So there were two anatomical landmarks, pectoralis and calcar area. So this was our, let's say, points of reference. Then the glenoid preparation was typical, so nothing interesting. However, suture management around tuberosities was exactly as recommended by Pascal Boileau. And after implantation of the stem, the sutures were going to pass around the stem and between tuberosities as well. So this is the view after prosthesis reposition. When I tried to localize all sutures to be ready to close the book, because we are trying to put all these sutures together around stem and also to fix it to the shaft. So this is final view of final fixation of tuberosities. So you see, I'm not excising the supraspinatus tendon, and this is X-ray after surgery. She was operated quite late due to some organization problems. However, her disease was so big, so we decided to do surgery even though. To conclude, I think that tuberosity, reverse prosthesis in fractures are always difficult. The problem remains the same, which is the proper height and healing of tuberosities. I find myself quite often overcorrecting the greater tuberosity, and I'm not sure how to avoid it. Results are possibly good. We also should look at the patient, because good patient selection is a first key to good results. And I'm not forgetting about non-operative treatment in sedentary patients. So thank you very much for your attention. Polish Shoulder Elbow Society, together with Polish Arthroscopic Society, are trying to help our Ukrainian friends who live in terrible situation. They have war in their country, so we are trying to send them as much equipment as possible. So I would like you to remember about their very difficult situation, and please try to help them as we are helping. Thank you very much.
Thank you, Bartek. I appreciate also your help to the Ukrainian people. Now it's turn of Paolo Paladini from Italy, who he will speak about reverse shoulder arthroplasty for calf tear arthropathy tips and tricks. Thank you, Paolo. It's your turn now.
Thank you, Ali. Thank you.
Dear friends of European Society for Shoulder Elbow Surgery, it's a pleasure to be here to be part of this webinar organized by the Eastern European Support Committee. My role is to speak about the surgical tips and how to evaluate the tension when we implant a reverse for calf tear arthropathy. There is a lot of literature how to expose the glenoid, how to evaluate the tension, and here I try to resume the best tips that we can have. First of all, it's important to have a good patient positioning, a good skin incision, a good subscapularis procedures, and inferior capsulotomy. This is the main steps that we can consider. First of all, it's so different to treat a shoulder like this that is already closed, is an ankylotic shoulder, respect to a shoulder like this that is so loosened. So we have two different kind of prosthesis, two different kind of patient, and two different kind of environments that we can face off. So normal, we have a small bolt volume in the shoulder, but when you have an arthritic, we can have a further bone loss. And if there is an eccentric wear, we have a retraction so difficult, and the implant is challenging, as told us by Lou Biliani. First of all, we have to mobilize the deltoid because there is some adhesion between the deltoid and the lateral facet of the humerus. And in this case, it's really difficult to have a good exposure and a good release of the humerus if we cannot have a good mobilization of the deltoid. Even the identification of the landmarks is important. First of all, we have to start identifying the cephalic vein and follow all the course of the cephalic vein from the clavicle to the insertion of the deltoid. To detach the capsule is really important. In this case, you can see that we are really careful detaching the capsule from the inferior part of the humerus, from the superior part, and releasing all this. This permits us to release all the hammock coming from the inferior part of the humerus to the inferior part of the glenoid. Sometimes we, when we put the humeral retractor on the posterior facet of the glenoid, we can have a fracture of the humeral, humeral tuberosity, anterior part of the humerus. Sometimes this is a useful impaction fracture. We can use this kind of fracture to have more space. And of course, if we are going to implant a reverse shoulder arthroplasty, this is not important for the outcome of this prosthesis. You can see that even the positioning of the patient is useful for the glenoid preparation. So in this case, we can put the patient in abduction, extension, and external rotation to release all the soft tissues that we can have, impeding us to reach the complete exposure of the glenoid. You can see that in this position, in external rotation, this can increase the distance between the axillary nerve that is anteriorly and the subscapularis. And in this case, we can even identify the three cysts located in the inferior border of this muscle. The humeral site preparation. In this case, we usually release all the osteophyte from the inferior and lateral side of the humerus. This can help us to reduce the dimension of the humeral head, and the shape of the humeral head. And in this case, we can have a better visualization of the glenoid when we release all the soft tissues from this osteophyte. Even the use of a clever instrumentation can help us. In this case, the humeral head, with the resection of the humeral head, we have more space. But if our reamer is an hemicircle and not a complete circle, this can help us to have more space in the posterior part. So these are the 10 content tips that we can find for the better visualization of the glenoid. First of all, tilting the operating table away from the surgical side, having a lot of variety of retractors available, removing all the humeral osteophyte, making accurate humeral cut to have more space. So we need a laminar spreader in select situation to have more space in the posterior side, so we can dislocate easily the humeral head posteriorly. And we have a proper retractor placement, as you can see on the left. In this case, with just 4 retractors, we can have a good visualization of the glenoid. It's important to remove completely all the anterior inferior capsule. In this case, we can have a good mobility of the subscap, and this can help us in the last step of the implant of position is over reverse prosthesis. And in this case, you can release all the posterior, all the capsule, leaving a lot of space for retractor and for implant of the glenoid. As you can see in this case, you can follow all the capsule even around the glenoid, even in the inferior part, removing safely all this capsule. And in this case, even for the posterior inferior part of the capsule, you can continue this release. But what about the tension? The tension is the most important part to have in a reverse shoulder prosthesis, because if you don't have enough tension, you can have instability of this kind of prosthesis. And you can see that the soft tissue imbalance with the anatomical prosthesis can lead to a dislocation of this humeral head, different in reverse shoulder prosthesis. You can see that the risk factor for instability are younger age, revision surgery, and even the militarization of the glenosphere, as it happens with the Grammont prosthesis. There is some attempt to evaluate the muscle tensioning in reverse shoulder arthroplasty, but I think that still this is not so simple to do, and even intraoperative measurement is so difficult, and the surgeon only opportunity to achieve optimal shoulder tensioning is during surgery. And so we have to learn some tips to understand when you have a good tensioning of the humeral, of the soft tissues and when not. Is it useful to have a conjoint tendon release? Sometimes when you have a too much tension, you have pain on the conjoint tendon, and there are different options from the Z lengthening of the conjoint tendon to the removal of the conjoint tendon completely. But how can we evaluate the tension? You can see that in this case, we can have some personal kind of tips for the tensioning. And sometimes we are not able to evaluate this tension. In this case, we are trying to reduce a glenoid prosthesis after implant, but unlikely, this reduction takes us to a fracture of the anterior part of the lesser tuberosity. In this case, we decided to release the posterior capsule, the posterior cuff, that the superior calf that we leave in the first time and we left attached, and after we had a complete reduction of this patient, of the complete reduction of the prosthesis. Of course, we need to create to do a cementation of this prosthesis, but the tension at the end is good. You can see here the suture of the subscap and the evaluation that we have done on the conjoint tendon. In conclusion, soft tissue release is the key to have a successful shoulder arthroplasty, but not too much tension, because when you can have an acromion fracture or scapular spine fracture or coracoid fracture or humeral fracture. Thank you for your attention.
Thank you, Paolo, for the nice presentation. Now, for the last presentation, Philippe Collin will talk about the painful reverse shoulder arthroplasty. Please, Philippe.
So thank you very much for this invitation. Thank you, Kerem, for the organization of this very interesting webinar. We are going to speak about pain after RSA when the X-ray is normal. It's not so frequent, but it's not so rare. And I totally agree that sometimes we don't know what to do in this kind of situation. So I'm going to try to summarize what I do in my daily practice. So I think the first question is when? Is it immediately after surgery in the 15 within days? Or is it 6 weeks after surgery? Is it between 3 and 6 months after surgery? Or it is between 1 year or later after surgery? I think it's very important to look at when does this pain occur. I think that if it's immediately after surgery, means within the 15 days after the surgery, you always need to know that pain is normal during 2 or 3 days, but not more. Because if the patient is painful more than 2 or 3 days, this pain may become chronic and you can be in trouble. So, of course, pain, we know that, everybody knows that it's a usual phenomenon. Usually it's less than 48 hours. And it's what we call that a primary hyperalgesia or an inflammation. And it's normal. And it's very well controlled with good painkiller. But sometimes, it's not so rare, but it's not so, you can observe that. You have a secondary hyperalgesia, or we can call it a neurological inflammation. The patient remains painful, very painful, and then, especially during the night, the physio is almost impossible. When you start to mobilize the shoulder, the patient is very, very, very painful. And if you put regular painkiller, like opiate, it's even worse. If you have this, if the patient is worse with the opioid, you need to think to this neurological inflammation. So what you need to do is you need to perform a secondary local anesthesia, or you can put ketamine to the patient, and it's very, very effective. So this is in the immediate post-op, the X-ray is normal, but the patient remains painful. Now, when you see the patient 6 weeks after the surgery, and if the patient is still painful, you need to look at the scar. Sometimes, as you can see here, there is a primary surgery through the deltoid. Here, you can see that. And the patient just shows to you where the pain is. Because there is a scar in the deltoid. And you know very well that you have an elongation of the fiber of the deltoid when you put a reverse shoulder arthroplasty. And this elongation of the fibers can be painful because there is a scar, a previous scar into the deltoid. So it may explain the pain at 6 weeks. You just need to explain to the patient that it's not a problem, just need to wait a bit, and most of the time the patient recovers. Now, if it's between 3 and 6 months after surgery, I don't like really this diagnosis, but sometimes it is not rare, but sometimes I have to confess that you need to think to what we call a complex regional pain syndrome type 1 or 2. I think that this diagnosis, we use it too much. Sometimes we don't dare to look for infection or to look for something else. It's really, if you have nothing, absolutely nothing, and especially if you have problem in the end, and especially in the metacarpal joint, and if you have an hypersudation of the end, then sometimes it's rare, but you can have a complex regional pain syndrome type 1 or 2. Now, if it's 1 year after surgery, 1 year after surgery, it's always the same. Always the same. The patient is doing very well. You've seen him at 6 months, it was okay. You've seen him at 1 year, it was okay. And then suddenly the patient becomes very painful. It's awful, very, very, very painful. Then you need immediately to think to a spine fracture. This is the main diagnosis. I would like to thank my very good friend Lionel Letton for the next slide from him. So you need to think to that. Look to this. It was a fracture. It was an X-ray at 1 year and a half after surgery. Everything is normal, but the patient is suddenly very, very, very painful. Everything was good, but after that the patient is painful. Then you need to ask a CT, as you can see here, and you have an hyperfixation here. This is very, very clear. And if you request a CT scan, you can see the spine fracture on the CT scan. Sometimes you look at everything and everything is absolutely normal. The CT scan is normal. Everything is normal. So you can ask. It's very, very useful. I encourage you to ask a TEP scan, as you can see here. On the TEP scan, you can see very well the fracture. These fractures are not so rare. As you can know, it has been classified by Jonathan Levy in GBGS. You have 3 types of fracture, type 1, type 2, and type 3. The main difficult one to treat are the type 2 and the type 3. If you look at the literature, you can see that the reported rate of spine fracture is between 0.8 and 50%. As you can see here, it's Tutsky reported 3%, Lionel Letton with the Grammont Award reported 1.3%, Rootman reported 1.5%. And recently, in a systematic review, the rate of fracture was almost 3%, so as you can see, it's not so rare. So is it possible to identify if you have a risk factor for this kind of fracture? You are going to look at this. So in fact, it's during the fact that we modified the center of rotation, during the fact that we have an increase of the deltoid moment arm and the arm lengthening, and the deltoid, you have deltoid tension, and you can have this kind of fracture. It can be, we know now that it's clearly related to the lateralization, related to the lateralization on the glenoid side. It is related to the the position of the central peg and the position of the superior screw. On the lateral, on the humeral side, it's also related to the lateralization, and it's more frequent on onlay design rather than inlay design. So as you can see here, the rate of if you have medialis humeralization, medialis humerus and lateralized glenoid, the rate of of this fracture is higher compared to the other kind of design. So another slide in order to explain that it's clearly associated to the rate of the implant design. Sometimes it's related to the, as you said, as I told you previously, to the position of the screw, as you can see here, especially the superior one. But now we are not really sure that it is related to this kind of screw. But the position of the central peg is really related to the spine fracture. We found other factors from the patient, like the gender. It's more frequent for the female. Regarding the disease, it's more frequent for rheumatoid arthritis, or it's, as you can see here, it's more frequent if you have a thickness of the acromion, and it's more frequent in case of osteoporosis. So you have two kinds of fracture. You have the stress fracture and the acute fracture. When it's a stress fracture, you can treat it conservatively in the abduction period during 6 weeks. But when it's a fresh fracture, then you can operate on them, as you can see on this slide. Just I encourage you to put 2 plates, not 1, but 2 plates if you have to operate on this patient. So in conclusion, for the spine fracture, the risk is between 1 and 4%. Risk factors are very difficult to identify, probably related to osteoporosis, probably related to the glenoid lateralization, humeral lateralization, or both, or the superior screw, but it's not sure. It's really a multifactorial problem. So sometimes you look at the X-ray, but you don't look inferiorly. And sometimes it's an allergy, as you can see here. You can see here that there is no problem on the ear, but the problem is here. Just look at the tip, and sometimes you can have an allergy of the peg. So the most frequent, in fact, the most frequent problem to have pain after a RSA. You can have pain after RSA after 15 days, 6 weeks, 3 or 6 months, or 1 year. At any time, you can have an infection. Infection is the most frequent problem in pain after reverse shoulder arthroplasty. Infection is, you need to always keep that in mind. First, you need to think about infection. So in any doubt, you can make a punction, you can make biopsy if you have any doubt. So now I would like to thank my good friend Robert Hudek for the next slide. He has a courtesy to give it to me because he's really specialized in infection. Of course, it's not really the debate today, but because we are speaking about pain after a reverse shoulder arthroplasty, but the most important, in fact, before to rule out an infection, is to avoid the infection. So in order to avoid infection, we know that it's, as I said previously, it's the most important complication after reverse shoulder arthroplasty. It's more frequent on the male and more frequent on a young patient, as you can see here. And everybody knows that the main bacteria is C. acnes, as you can see. So now, what can you do in order to avoid infection? BPO is useful. It has been published for the NEAR Award 2018. Skin preparation is very useful too. It has been published in this paper. And in this paper, they just check which was the best product in order for the skin preparation. And as you can see, one is better than the other one. So now, is it useful to make a decolonization in the noise? It is. It has been published here. You can do that in order to avoid infection. And of course, the best, of course, as well, it's very useful to change the skin knife blades during surgery. Wound irrigation with povidone and iodine is very useful at the end of the surgery. So in conclusion, if it's a before just after the surgery, within the 15 days, think about hyperalgesia or neurological inflammation. If it's 6 weeks after surgery, look if there is not a previous scar in the deltoid. If it's between 3 and 6 months after surgery, it could be regional pain syndrome type 1 or 2. 1 year after surgery, it's a spine fracture, but always keep in mind, always just after day 1 after surgery and after 10 years follow-up, infection is the main problem for pain after reverse arthroplasty. Thank you very much. Thank you for your attention.
Thank you, Philippe, for the presentation. Now, for the discussion, we have a couple of questions. The first question is from Turkey. I think it's better to Bartek. Do you recommend using an inlay glenoid component for better fix the tuberosity fragments? What is your opinion about that, Bartek? You are muted.
Sorry. Not really sure whether this matters. I like several types of let's say prosthesis, which I'm not related, but I like Tournier, and I use Zimmer prosthesis as they have some options to fix tuberosities. You know, we have this sliding, this in Tournier prosthesis, you have this possibility to pass the sutures around the stem, which is polished, which means that you can use sutures and they are not going to be disturbed by the stem. And in Zimmer, I have open channels for the sutures. So I think the fixation type is more important than the name of prosthesis. So if we have possibility to fix the tuberosities well, it's good. So I'm not so experienced in many types of prosthesis to tell you which type is better. But I think there's only one question, whether you can manage your sutures or not.
Yeah, thank you. I extend the question a little bit to Dr. Kerem. If you have all kind of designs available with you, which is not possible in Turkey, how do you decide which type of design you use for a patient? Medialized from glenoid, humerus, lateralized glenoid, lateralized humerus. How do you decide the design?
Thank you, Ali, for your great question. As you know, we all started with Grammon type prosthesis 15 years ago in Turkey, and we got some results from them. We learned something, especially we used in fracture case and CTA cases. And we saw that after 10 years, we had some part of our patient, scapular notching, glenoid loosening, and some part, the polyethylene wear, and it caused some humeral loosening also. So as we got in the market the lateralized one, we maybe 10 years ago, we now have the possibility to use medialized and lateralized. But in my part, in fracture cases, I usually go for the medialized one, the Grammon one, because I can fix the tuberosities well, and I got the union in tuberosities in this position, and I'm not afraid of the scapular notching in fracture cases. But in CTA cases, in the skinny one, the small and tiny patients, I don't like to go to lateralized prosthesis because it can cause some, spine fractures and acromial fracture. But usually I use the lateralized, especially from the humeral part, the onlay prosthesis. In case of glenoid bone loss, I use the bio-RSA options with the lateralized humerus, onlay humerus. My trend is going a little bit to onlay and lateralized prosthesis.
Thank you. There is another question about fracture to Bartek. Do you cement the humeral component, the stem, or cementless? How do you choose between cement and cementless?
I would say that 80% of cases I'm cementing stem because my first goal is to find the proper height and to find place for tuberosities. So this is when I choose a proper height, I stop going farther. So it's very rarely to have case when you put a stem which has two features: being high enough to fix the tuberosities and being big enough to fulfill the space and to give you proper cementless fixation. So I would say that 90 to 95% of my fracture cases, I have to cement the stem.
Ali, if you allow me, can we extend the same question for the remaining faculty?
Sure.
Kerem, Philippe, Paolo, do you cement or not cement the stem in fracture cases? And if you do, when do you do it?
Usually never. In my cases, usually I implant cementless prosthesis with a stem.
Kerem?
In my part, I usually use cementless prosthesis, but in osteoporotic ones, I go for the cement, but very few nowadays.
And Philippe?
I always cement because the risk is if you have loosening of the tuberosity, then you will have a loss of forces on the humerus side, and the risk of loosening is higher.
Emilio, what is your opinion about that?
Well, you can see here that there's a big difference between the speakers. I can tell you that initially I used to cement all stems in fracture cases. Then I started to trying to avoid cement in most of them. And then I moved to a design where if there is some press fit in the metaphyseal area, I do not cement. So unless there is a clear fixation only relying part of the stem, where it says there is a risk of rotational moment forces that can loosen the stem. Whenever I have a good or a strong fixation at the metaphyseal area, I try not to cement. And I think it can be obtained in the majority of the cases.
So between us, the stemless is one, I think. Cementless is one, because I also try to not cement the humeral component. So one more question about rehabilitation, post-op rehabilitation. What is your rehabilitation program after reverse shoulder arthroplasty and the difference between reverse and anatomic total shoulder? We start this time from Philippe.
It's a huge question. We could do a webinar just for that. Because I prefer perhaps to focus, depend on if I repair the subscap or not. If I don't repair the subscap, then I put no sling, nothing, just immediate all range of motion because I have nothing to protect. If I reattach the subscap, I will put a sling for 6 weeks in order to protect the subscap.
Thank you. Paolo?
Quite the same, but usually in anatomical prosthesis, you have to wait to use the strength for the rotator cuff. So you have to wait just 4 weeks in our cases to begin active internal and external rotation. For reverse shoulder arthroplasty, even in presence of reattachment of the subscap, we prefer to start after 2 weeks with the mobility of the shoulder and with the reinforcing the use of the subscap, because we trust more on deltoid than on this kind of muscles.
And Bartek and Kerem, any difference in rehabilitation program or just the same?
For my part, I keep all my patients, all my indications 1 month in brace. Rotator cuff, reverse, total anatomic, everything. I don't change my protocol. It's easy for me and for my patients. I don't change my protocol, but I give some isometric exercises and passive motions, and I give them free on the table, eating something, making something, computer or iPad. So 1 month brace protection for me, for every case.
Bartek, any difference?
Yes, because I have 3 protocols for my cases. I mean, if I do just a reverse, I never suture, I stopped suturing subscapularis in these cases. So I just do 3 days of sling just as a painkiller, and then the patients start to do whatever they can very gently. In fracture cases, I like to have 6 weeks of immobilization because I would like the tuberosities to heal. And in anatomic prosthesis, because I do this using a regular normal approach with a cutting subscapularis, I would like subscapularis to be healed because I think it's important. So in this case, I put patients in a sling for, let's say, 3 to 4 weeks, not longer, and they start to move afterwards.
What is your reason for not repairing subscap after a reverse when it is easy repairable?
Sometimes subscapularis is so good, and I would say it's asking for being repaired. So in this case, I see my residents who are saying it's so good, please repair it. So then I repair it. No, I mean, there is no pure data in studies saying it should be done or not. I always tried to repair it before. But first of all, I had some difficulties because sometimes the position of humerus is slightly changed. Okay, so the tension of subscap is not the same as anatomic prosthesis. So I'm not sure whether this is going to give me any, let's say, cuff activity. And I think the main stability is proven by proper implant orientation and deltoid tension. So as I have no proofs of subscapularis repair superiority over not repairing this, I think that sometimes in these patients it's better to be quicker. It's better to spare less time in operation in open wound because it's always risk factor for infection. Putting in less sutures because it's always sutures can be risk factor for infection as well. So I stopped suturing subscapularis in this, let's say, doughty cases. If it's really good subscapularis, sometimes I repair that. I'm trying not to do this. And even in the reverse cases, when I repair it, I let them move because I don't really believe they need to wait till subscapular is going to heal. So I know it's a controversial topic. So I just did a small revolution from repairing not to repair and to not repair it. Yes, please comment on.
I have a question for you. When you repair a cuff without prosthesis, a subscap tear, how long do you immobilize it?
When I repair in anatomic or reverse?
No, rotator cuff repair. No prosthesis.
Okay. It depends if it's a massive calf and I repair.
Subscap, isolated subscap.
Isolated subscap. I keep them in immobilized for 4 weeks and then 2 another weeks for nights.
So for an isolated subscap, almost 6 weeks.
4 weeks.
And for prosthesis, anatomic prosthesis, we know that the subscap is very, very important. Only 3 weeks.
Yes, because I think that I will tell you why. Because I think that my patients are usually older patients. They are less active. So I'm trying to explain them that they can use their hand very gently. And they are not as quick as most of patients with calf repair. Yes, I've noticed that maybe for the prosthesis it's better. In cases where I have patients with a calf problem, I think my crucial way is to heal it, so I prefer them to be stiff and then go slowly to regain forces, because their expectations after calf repair are probably much higher than expectations of my patients after prosthesis.
Yeah, questions are coming. So one more question about lateralization during surgery. How do you decide that you lateralize enough during surgery? Can we use coracoid process or acromion as a reference during surgery? Starting from Kerem Bilsel.
It's a very hard question to answer, because during the surgery, how much lateralization I get, I don't have any reference, but we have to, the reference point is the glenoid, should be glenoid, because in the JD Wörtel study, always we have the reference point is the glenoid. And if you want to compare the prosthesis, the reference point, your 0 point is delta 3. But this could be maybe a topic for a new study, I guess. Can be, maybe, in my opinion, can be the coracoid base, maybe. It's stable, because glenoid can be, you know, can have the bone loss in glenoid. Acromion is not a good choice, I guess. But it's better to use the preoperative planning. We don't have this opportunity in Turkey nowadays. Maybe in 3 months we will have. But if we have preoperative planning, 3D planning, we can guess and we can optimize our lateralization.
Sure.
I think.
Thank you. Paolo, what is your opinion about during surgery reference for lateralization?
I think that it's really hard to decide to lateralize during surgery or not. During surgery, you can choose if you don't feel enough tension, or if you feel that there is too much tension. I think that deciding to lateralize or not is a preoperative approach. You don't need even a virtual implantation of prosthesis to decide this. You just need a good CT scan, because you can see how deep is the glenoid, how glenoid you miss, which is the version of the glenoid, which kind of lateralization you need. And I think that is really important. Sometimes during surgery, you find a very lax patient, very loose in shoulder. In this case, of course, you have to do some trials. And I think that the tension on the soft tissues is the best way to understand if you have done something right or wrong.
Thank you. One more question for Dr. Collin. In case of painful reverse shoulder in the first 2 weeks, do you use any anesthetic injections, or I extended any blocks like scalene block or something like that?
Yes, I think it's not frequent what I told about, but when it occurs, most of the time we are very disappointed because we don't know what to do. It's a secondary hyperalgesia. It's a nerve inflammatory, and you need to keep in mind just one thing: is the fact that if you give opioid, it's worse. It's very rare, but it's worse. So the patient is very, very, very painful. You give him opioid, and after opioid, it's worse. So if you have that, just think about this. And then, of course, it is very useful to have the patient to perform an intrascalenic block. It's very useful to do that, yes. And you can give as well gabapentin.
Yeah.
May I make a question to Philippe regarding pain after reverse? I totally agree that the most common cause of pain after reverse shoulder arthroplasty is infection, but there are other possibilities, as you very well pointed out. My question is, when do you do the workout, the diagnostic workout to rule out infection? Do you do it in every case? And in every time after surgery? And what is your workout to rule out infection? You do lab tests. We're talking about biopsies or obtaining samples with articular puncture. What do you do?
Yes, thank you, Emilio. I understand what you mean. So what I do, of course, I do lab tests. But if, for example, I wait already 3 months, if lab test is okay, normal. If on the X-ray there is nothing, no apposition, nothing, and after 3 or 4 months, if everything is absolutely normal and the patient is still really painful, and then I will perform punction. Yes.
Do you ever do arthroscopic biopsies?
I've done, but I was a bit disappointed. I've done some, yes, but I'm always anxious to make the treatment more difficult than the disease. I mean that I was anxious to put an injection with my scope when there was no infection. In fact, that's my point.
Okay, thank you very much. Thank you very much. May I make a question about tension, because both of you or 3 of you were talking about the importance of tension. First, regarding fractures, very important tension on how to place the prosthesis. Paolo also talked about tension, and the same Philippe. To the 4 of you, how do you judge the tension of the prosthesis? So, Kerem, please, first.
Yeah, I check after my reduction. I check the conjoint tendon tension and deltoid. If the tension is too much, it's a subjective feeling, just feeling. I don't have any measurement for that, but this is due to the experience. Maybe Philippe can argue is much more experienced from me, but if I feel some tension, I make some release that Paolo showed me in his presentation, some release like CP cases, hamstring release, level release, and if I have so much tension, I change the insert, or if it's modular, I can cut the humerus more, because I had bad experience, Emilio. After tight reductions, I had one patient had some musculocutaneous nerve palsy without biceps function, and the day after I revise it, I put a smaller one, small insert tray, and she was completely restored in terms of neurologic.
So, Paolo, how do you judge tension while surgery?
I can give you some. I can tell you something about my experience. First, we try to reduce the dislocation of the shoulder using a lever to make the most of tension that we can do. In the first prosthesis that I did with Giuseppe Porcellini, and we use a lever because with a lot of traction. And now we change it a lot. If there is too much tension, we shorten the prosthesis, we shorten the liner, and I think that a reduction of this kind of prosthesis now is something quite normal, due without any kind of effort. You just put the arm in internal rotation, going in adduction, and with your finger, you just reduce the prosthesis. I think that you don't have to try to have so much tension, because you have pain on the conjoint tendon, you have a deltoid that is painful for the first weeks, and you increase the risk of acromial fracture, spine fracture, coracoid fracture. So I think that in the first time with the old prosthesis, with our experience on shoulder prosthesis, we try to have a very, very closed, stiff prosthesis. Now I think that our trend is completely different.
So you always try to avoid a difficult reduction.
Yes.
And that's the major take-home message. Bartek?
Usually, if I reach the equator of the glenosphere with my liner, I don't try to use another one. I just try use this. I use the liner. I use the trial liner as a marker. If I reach the equator, I know that I can reduce this kind of shoulder. So I don't put this inside. I just remove the trial, put the definitive one, and reduce the prosthesis.
Bartek, any tip or trick?
No, because my evolution was the same as Paolo just said. I was trying to be very, have this strong feeling of really fighting with reposition. Now I like the reposition to be a little bit more than just one finger reposition. However, if it's too tight, it's wrong. There is a high risk of fracture, and there is the patients are getting stiff. So I'm trying to be have some tension, but I would say this is the least tension I'm happy with. So it's a very personal feeling, and it's a pity because I cannot give you any just a proper, I would say, mnemotechnic device how to do this. Maybe you guys have something more than this.
Philippe, any tip on how to judge tension in lateralization?
No, but I'm always a bit confused because when I listen to this, because I do almost nothing, almost nothing. I just try to reduce. If I can reduce, I stop. It's finished for me. It means that the tension is good. If I cannot reduce, I will cut the humerus in order to be able to reduce. And if I reduce, and I have the feeling that it's a bit, I have some loosening, I will be really more anxious about that rather than too much tension in order to avoid dislocation. So if I reduce too easily, it means that very easily I will try to increase the length of the tray or something like that. But most of the time I just reduce, and if it's okay, that's okay. I don't mind. I check nothing.
Philippe, do you ever use lever systems, or do you try to avoid them?
No, I just reduce like that, and that's it. If I can reduce, it's finished for me. In fact, now it's really easier than it was in the past. I don't try to check everything. In fact, I check nothing.
Okay. Ali, any other question or comment?
I think, Emilio, we are just on time, what we planned. So the questions are finished. So I think we did a good job for the first webinar of our committee. If you allow me, I think we can close now the webinar, and you can close the webinar, I think. So thank you for all the faculty and the participants to join our webinar. And I hope we can also do the second and third of our committee webinars with your help, of course. Thank you.
Thank you very much, Ali. Thank you to all the speakers. It's been a real big success. I found it very interesting. Many people connected following the webinar. So thank you, Ali. Thank you, my friends, for your help. Thank you, Sylvie. And see you, as Ali said, in the next Eastern European countries committee webinars. Thank you very much.